Hi, my name is Aaron Gerds, and I'm the editor-in-chief of ASH Clinical News. We're here at the ASH annual meeting for 2023 with on-site coverage for you of some of the really salient abstracts from this year's meeting. Of course, there's a lot of material we have online with ASH Clinical News, so feel free to peruse the website when you get a chance. So it's my distinct pleasure again today and throughout the course of the meeting to present these really poignant abstracts for the meeting. And today we have a wonderful abstract in pediatrics, which often goes somewhat underrepresented in our magazine, I know, and that's something we're trying to address. So would you just start for our audience introducing yourself, and then we'll jump into the specifics of your abstract.
Yeah, nice to meet you. I'm Dr. Stephen Pipe. I'm a professor of pediatrics and pathology at the University of Michigan, and my primary area of focus is in inherited bleeding disorders.
Yeah. Well, thank you so much for joining us today, Dr. Pipe. Your abstract was certainly interesting, and I think to me the headline was trying to address an unmet need for some of our youngest patients with blood disorders. And so I again congratulate you on your work and your presentation yesterday here at the annual meeting. Just kind of start off with, for these young patients with hemophilia, what is the standard treatment?
Yeah, so until recently, the standard treatment for all patients with severe hemophilia A has been regular IV infusions of factor VIII replacement therapy. And we've been able to do that in infants only really starting by about a year of age. As you can imagine, the practicality of having to learn intravenous infusion with very young infants, it's really meant that prophylaxis was pushed out, beyond the first year of life. And so the challenge there is the bleeding phenotype is still there throughout that first year. And we've seen that babies can accumulate bleeding events over that first year. And as they get more mobile, this becomes more and more of a concern. But one of the biggest treatment gaps we've had is this risk of intracranial hemorrhage. This can occur between 4 to 8% of infants over the first year of life if they're not on a regular prophylactic therapy. So Emicizumab is a humanized monoclonal antibody. It's a bispecific antibody. It substitutes for the role of factor VIII. And it's been approved and available in the US, including for infants, for several years now. But if we look at the clinical trial experience, in the very youngest infants, this population was relatively underrepresented in the clinical trial program. So the community had really, they'd identified this treatment gap, they saw how emicizumab could really meet this, but they really wanted some good prospective data to support both the safety and the efficacy. So that was the design of the VIII trial.
Yeah, I remember back to my pediatric days a long time ago when I was a medical student. For those young patients, you do interosseous kind of infusions and stuff, and so I can imagine, starting IVs in those little children must be very difficult. So how's this drug given to these patients?
Yeah, so because it's a monoclonal antibody, it actually has excellent bioavailability when given subcutaneous, so that's the big advantage. But it's also a very long half-life, up to almost 30 days. So the approved maintenance regimens is actually once a week, every 2 weeks, every 4 weeks. Now, for uniformity in this trial, all of the infants received a loading dose of once weekly sub-Q injections. That takes them up to a steady state level. And then they were all on the same maintenance regimen of 3 milligrams per kilogram subcutaneously every 2 weeks. And we followed them all the way through a full year of follow-up. At the end of that year, the families could choose to either go to any of the 3 approved regimens. And as it turned out, the majority of the families just continued on the every 2-week dosing. There was a few percentage of families that went to the every 4-week regimen.
And emicizumab, it can be self-administered, or do they have to come to the clinic to get it?
No, we can give this in the home setting. So we teach all the families, and this just adds to the convenience and ensures a high level of adherence, which we saw throughout the trial, actually.
That's a really important point, adherence, because it's not going to work if you don't take it.
Right.
With respect to the trial design, so usually, as an adult hematologist, I see a phase 3B trial, and I think randomized against placebo or a control arm. So can you tell me a little bit about the phase 3 design of this study?
Yeah, so this was a phase 3b open label study. It was a single arm, so there was no control group or randomization. And really we discussed this, but there was just not going to be any buy-in because of the burden of doing IV prophylaxis in the youngest infants. We just knew we weren't going to be able to do a design that way.
Yeah, it would be incredibly difficult to enroll, I would imagine. And then your primary endpoint was this modeling for events. Could you explain that modeling process?
Yeah, so what we do in almost all of the hemophilia trials to evaluate efficacy is to look at what we call an annualized bleed rate. Now, we have to accommodate for varying levels of follow-up between the patients and also somewhat the randomness of when bleeds occur. So we use a negative binomial a modeled approach for the ABR, and so that's what the readout is. And so the primary readout for this were several efficacy endpoints. We wanted to look at treated bleeds, so those that resulted in a need for a factor VIII infusion. This is an important distinction about emicizumab. It's a very effective prophylactic agent, but you still need to rely on factor VIII for any breakthrough bleeding events. So we looked at treated bleeds. We looked at all bleeds, so whether they got a treatment or not. And then we looked at treated spontaneous bleeds, which really is the hallmark of severe hemophilic bleeding. And then we also looked at treated joint bleeds.
And of course, definitely reduction in those anticipated bleeding events was seen, and I think that's a very positive effect of this. And likewise, it didn't seem like the side effects or the adverse events were overwhelming. Could you kind of just give us a sense of what type of adverse events we're seeing on study?
Yeah, so no new safety signals in this trial that we hadn't seen before with emicizumab in the older children and adults. Importantly, there were no anti-drug antibodies directed against emicizumab. This is actually maybe even a little bit surprising because we have seen a low rate of ADAs in older children and adults, but that's an important observation in this trial. A second safety issue, we've seen no thrombotic issues, we've seen no TMAs, so this was encouraging. And then the other aspect of immunogenicity that we had an opportunity to evaluate was immunogenicity against factor VIII in response to exposures. As you may know, in severe hemophilia, infants, it's about 1/3 to 40% of infants will develop an immune response to infused factor VIII, and these inhibitors neutralize the function of factor VIII. So this is the most significant complication of regular factor VIII infusions. We anticipated that emicizumab as an effective prophylaxis agent would reduce factor VIII exposures, and we hypothesized that we would see a reduced number of inhibitors. So as it turned out, half of the infants over 100 weeks of follow-up have had no exposures to factor VIII. So that was impressive. In the other, I think, 28 patients who'd had at least one exposure to factor VIII, 24 of them had inhibitor evaluations. So the triggers for getting an inhibitor assay were if you had every 3 exposure days, you were to get an inhibitor screen, and then after back-to-back or consecutive exposures, then you would trigger inhibitor. So 24 of the infants triggered the inhibitor evaluation. We've only seen 2 inhibitors to date. They all happened well into the second year of follow-up. It's related to factor VIII exposures, of course, but one of the beautiful aspects of emicizumab as a prophylactic agent, it looks nothing like factor VIII.
Yeah.
So you don't lose the prophylactic efficacy. So these 2 infants have just continued on emicizumab prophylaxis, and they're maintaining, good protection from breakthrough bleeding.
I mean, that's fantastic. Not seeing significant numbers of anti-drug antibodies, and then on top of it, no exposure to factor VIII. It's pretty hard to make inhibitors if you don't see the drug.
Exactly.
So I mean, I think that's just absolutely phenomenal results for this trial in terms of adverse events and like downstream effects of the treatment. So going forward, does this change the standard care for these tiniest of our patients, and is it immediately a practice changing?
Yeah. So the study wasn't powered to evaluate whether we can claim that it, abrogates all intracranial hemorrhages. But we had 55 infants enrolled. They've all passed a year of follow-up. 100 weeks was the median follow-up period. We had, at the clinical cutoff date, the median age was 29 months. So these are fully mobilized toddlers. So the fact that we had no intracranial hemorrhages over the course of this trial so far, I think is impressive. And noting that treatment gap that we talked about, and the fact that we're seeing excellent control of bleeding, the overall treated bleed rate in this trial was 0.4. And we had no treated spontaneous bleeds across any of the infants. So 100% of the infants were free of spontaneous bleeding, as we said, the hallmark of hemophilic bleeding. So in my mind, I think this has demonstrated the safety and efficacy that we want from a prophylactic agent. And I think really this should be the new standard of care for how we manage infants in the first year of life. I think we haven't really had an approach that allowed us to do very early prophylaxis. One of the things you'll see in the abstract is half of the infants were under 3 months of age at the time of enrollment. And we had one infant that was as early as 9 days of age enrolled into this trial. And I can tell you my clinical practice, outside of the clinical trial, I have been managing infants in this fashion for several years now. And we essentially have replicated the results from VIII. We've been able to get infants as very early as possible onto prophylaxis, and we're realizing the same bleed protection that we see in the VIII results.
Are there any plans then to gather that real-world data and compare it against VIII?
So we have some mechanisms here in the U.S. ATHN is the American Thrombosis and Hemostasis Network, and virtually all of the hemophilia treatment centers across the country participate in that network for data collection. And there is a module in there called ATHN Transcends, where we can follow cohorts of patients. And I hope that increasingly we'll see that data accumulate in that cohort group in our national network, and we can report out over the longer term. What's nice about the way the VIII was designed is after this first year, when they've gone on the long-term maintenance, we're going to continue to follow them over the next 6 years. And that's going to allow us to accumulate additional safety and efficacy data. But importantly, we have plans to do MRI assessments on joints at the end of the study.
Oh, wow.
And that will give us a first readout of long-term joint health in infants who have been exclusively maintained on prophylaxis with emicizumab since very early in life. And I think this really will be a game changer for how we think about these non-factor therapies in severe hemophilia.
Oh, that's fantastic. So something to look forward to at ASH 2029 then, huh? So we'll certainly anticipate those results eagerly. Well, thank you so much for joining us today here at ASH Clinical News. It's been an absolute pleasure to speak with you about the VIII trial and all your wonderful work. I could absolutely congratulate you on all of your efforts, taking care of some of our youngest patients with blood disorders.
Thank you.
And I'd like to thank you for listening in on our conversation about this abstract. And I would just remind you that if you want to read more about this abstract, it is on ASH's website, hematology.org, as is all the abstracts for the ASH annual meeting this year. And then you can view all of our online coverage from ASH Clinical News as well. So thank you so much for tuning in today, and we'll see you next time.